Sir, you are live. Over to you.
First of all, I'd like to thank Lupin for giving me an opportunity to talk a few words about this particular topic. My topic is the role of statin and DAPT in post-MI, post-PCI and CABG patients. Coming to hospitalization, in fact, once the patient get hospitalized, with acute coronary syndrome, what you have to do, you have to look for the acute care which has to be given to the patient immediately, whether it is drug therapy or coronary revascularization. And you have to go for cardiovascular risk assessment. That is, conceal and control risk factors as to be exposed and treated accordingly. Then initiate secondary prevention and set treatment goals. And you have to plan and schedule cardiac rehabilitation. You have to educate the patient, go do some counseling, and you have to give cardioprotective drugs in secondary prevention. And then the education and counseling part, you got the risk factor control. There is a weight control, smoking cessation, blood pressure, lipid control, so on. Diet and nutritional counseling, physical activity counseling and exercise training, psychosocial management, sex advice, and vocational advice. Again, regarding the rescheduling of cardiac rehabilitation, cardiac rehabilitation program has to be attended. So cardioprotective drugs, as you all know, includes antithrombotic drug therapy, which include aspirin and P2Y2 Y12 inhibitors for 12 months on average, lipid lowering, that is high-intensity statin therapy, then blood pressure, heart failure control using ACE inhibitors, ARBs, beta blockers, and MRAs, and glucose control using metformin, insulin, and other OHAs. So basically, re-evaluate lifestyle, control risk factors, psychosocial factors, and adherence to therapy has to be promised. Then adjustment of secondary prevention strategies, consider polypill if needed. But coming to the secondary prevention for patients with history of myocardial infarction, what are the key considerations? Stable outpatient history of thrombosis remain, in fact, a heightened risk of ischemic events for long term. So fundamental aspects of secondary prevention has to be taken care of. Now coming to the intervention and what is new, you've got lifestyle interventions, which include patient engagement and empowerment. You've got the beta blockers, that is debate over long-term benefit. Is still going on. Dyslipidemia provides guidelines and non-statin treatment as coming over the top recently. Control of hypertension, again, got revised targets. Renin aldosterone inhibition, mostly it is underused. And of course, the antithrombotic therapies. New agents are there of how to treat which agents and how long. So a lot of new things added on to these drugs, as well as the treatment strategy per se of acute coronary syndromes. Of course, this picture shows poorly controlled LDL-C continues to loom over millions of lives. So treatment goes for LDL cholesterol across the categories of total cardiovascular disease risk. Now we can categorize them into different schools, for which the treatment is given, whether it is should be less than 55 for very high risk categories, which include ASCVD, a score of more than 10%, the family history of ASCVD, overweight, another major risk factor, severe chronic kidney disease, that is the eGFR of less than 30, diabetes or target organ damage of more than equal to 3 major risk factors, and so on. And a stringent control of 70 milligram per deciliter or less is required for a score of more than 5% and less than 10%, and markedly elevated single risk factors, in particular total cholesterol of more than 310 milligram per deciliters, and LDL cholesterol of more than 190 with a BP of more than 180 over 110. Family history without major risk factors, moderate CKD with an eGFR of 30 to 59, diabetes mellitus without any target organ damage, or with diabetes mellitus of more than 10 years of additional risk factors. Now, 100 milligram per deciliter or less is enough for moderate control, that is a score of more than 1 and less than 5. Young patients, especially with those people with diabetes type 1 more than less than 35 years of age, and type 2 diabetes less than 50 years of age, and diabetes duration of less than 10 years. And of course, the stringent control of around 160 milligram per deciliter is required. The score is less than 1%. So this is how you divide and categorize those patients with, the cardiovascular disease or no disease with risk factors, and the level of the lipids that is to be put under control. Now, coming to the recommendations for treatment goals for LDL cholesterol, the recommendations, of course, the ESC 2020 has said that in secondary prevention patients at very high risk, an LDL-C reduction of at least 50% from the baseline and an LDL-C goal of less than 1.4 millimoles per liter or less than 55 milligram per deciliter is a class 1A recommendation. Now, again, recommendations for pharmacological LDL cholesterol lowering. You've got the recommendation of high-intensity statin up to the highest tolerated doses, of course, advised to reach the goal set for specific levels of risk. This is a 1A recommendation. And if the goals are not achieved with the maximum tolerated dose of statin, a combination with ezetimibe is recommended. So that's a 1B recommendation. Now, coming to the recommendations for pharmacological low-density lipoprotein cholesterol lowering, continuing, for secondary prevention, patients at very high risk, are not achieving their goal of a maximum tolerated dose of statin and ezetimibe. A combination with PCSK9 inhibitor is recommended. That's a 1A recommendation. Now, what about the risk reduction for CHD events as a function of the changes in TC, LDL-C, and HDL-C? The percent of change of LDL-C, if it is decreased by 1%, the CHD event rate is decreased by 1%. The total cholesterol, if it is decreased by 1%, you've got a 2% decrease in the CHD event rate. And of course, HDL-C, if it is increased by 1%, you've got a maximum benefit of decrease in the CHD event rate by 3%. This is based on all those trials in 4S, CABG, Petroscopes, Helsinki, WAHIT, FCAPS, and so on. Now, coming to the evidence for chronic cardiovascular disease prevention guidelines, you got the antiplatelet therapy and all these evidence-based guidelines. You've got the antiplatelet therapy targets you take into consideration. You've got the ATP, which is an important target for clopidogrel, ticagrelor, prasugrel, and ticagrelor. And G2P3 inhibitors, as you all know, of course, cyclooxygenase inhibitor, the aspirin, and you've got dipyridamole acting on the phosphodiesterase. So all these things ultimately will end up acting on collagen, thrombin, thromboxane, A2, and so on. Now, coming to the antiplatelet therapy in short, you've got the different classes. You've got acetyl salicylic acid or aspirin. Is salicylate, and the formulation is supposed to be an active drug, and the maintenance dose is around 75 to 325 milligram daily, and it's not reversible. You've got ticagrelor, which is a P2Y12 receptor antagonist. It's an active drug with a 250 milligram BID dose, and it's not reversible again. And it's, of course, obsolete nowadays. Clopidogrel bisulfate is a P2Y12 receptor antagonist, and it's a prodrug, 75 milligram daily use, and it's again not reversible. And prasugrel again is a P2Y12 receptor antagonist. It's a prodrug, 10 milligram daily dose, and it's not reversible. You've got ticagrelor, which is a P2Y12 receptor antagonist. It's a very active drug, and the dose is 90 milligram BID, and it is reversible. Now, coming to the aspirin evidence, so secondary prevention effects of antiplatelet treatment on vascular events. If you take aspirin use, it is used for a lot of events apart from ACS, be it CVA, be it PAT, embolism, and so on. You can see that aspirin, the red with the squares or quadrangular dots that you can see over the odds ratio, it's moved towards the antiplatelet better side. And what you can see that aspirin actually reduces the risk of adverse cardiovascular events. be it acute MI, be it prior MI, CVA, CVD, PAD, and so on. Most of the trials have proven that it reduces the risk of cardiovascular events. Again, effective aspirin doses on the vascular events in high-risk patients. You can see that the blue boxes, the maximum on the left side is 70 to 150 milligram. And maybe the trial is a little bit less, but what ultimately proves is that high dose of aspirin does not provide does not provide any improved efficacy. So the maximum benefit is around, say, 75 to 150 milligram daily of aspirin. Now, coming to again the evidence for aspirin, you've got the current Oasis 7 trial where we got around 25,000 patients with ACS randomized in a 2:2 factorial trial at a dose of clopidogrel versus standard dose clopidogrel and high dose of aspirin versus low dose of aspirin. What is proven is that you can see that the red and green lines go together. So it's like a high dose of aspirin does not provide any benefit in ACS. So you can always opt for a medium dose of aspirin. Again, aspirin recommendations. So for secondary prevention, aspirin of 75 to 162 milligram daily if non-CAD or NSTEMI is a class 1 recommendation. Again, 81 to 325 milligram daily of aspirin following a PCI or fibrinolytic therapy for STEMI, again, is a 1A recommendation. So 2A recommendation is in fact aspirin following a PCA for NSTEMI or STEMI or fibrinolytic therapy for a STEMI. Now coming to the secondary prevention, aspirin of 160 to 325 milligram daily for at least around 1 month after bare metal stent implantation is a class 1 recommendation. At least 3 months after sirolimus eluting stent implantation is again a class 1 indication, and at least 6 months after paclitaxel eluting stent implantation is a class 1 recommendation, after which aspirin should be continued. I repeat, should be continued after which indefinitely for a bare metal stent and for a diluting stent. So coming to aspirin, 75 to 162 milligram daily is in fact an initial dose after stent implantation in those at a very high bleeding risk, which is a class 2AC recommendation. So coming to the secondary prevention, aspirin following CABG surgery is of course a class 1 indication. Dose is around 100 to 325 milligram daily. Now coming to clopidogrel evidence, clopidogrel versus aspirin in patients at risk of ischemic events. That's a TAPT trial has studied around 20,000 patients with ischemic CVA, myocardial infarction, PAD, Pantomime 6.2, aspirin of 325 milligram or clopidogrel of 75 milligram for 2 years. But proven is that clopidogrel slightly provides slightly greater risk reduction than aspirin. As you can see, the cumulative risk is less, the p-value of 0.043 for the supporting the clopidogrel. In fact, the red line is a little bit below the green line. And coming to clopidogrel use in unstable angina to prevent recurrent events, a secure trial, we got around 12,000 patients with NSTEMI randomized to aspirin of 75 to 325 milligram or clopidogrel of around 300 loading and 75 milligram thereafter, plus aspirin for 9 months. In fact, the dual antiplatelet therapy, what cure trial has proven is that it's more efficacious in a non-ST elevation myocardial You can see that the red line is far below the green line. That means the rate of CV death, myocardial infarction, or stroke, the x-axis is far more less with aspirin and clopidogrel with a significant p-value of less than 0.001. So again, you've got the Credo trial, which is in fact the clopidogrel for traction of events during observation. There is a Credo trial. It's observed around 22,000 patients that are going PCA were randomized over 4 weeks of DAPT, followed by aspirin monotherapy versus persistent DAPT for 1 year. What has proven that the DAPT therapy provides great benefit when used for approximately 1 year. So the red line is again far below and is quite significant with a p-value of 0.02. Again, clopidogrel and metoprolol in myocardial infarction trial, concentrate more on clopidogrel and myocardial infarction, the coming trial. You got around 45,000, a whopping 45,000 patients presenting within around 24 hours A STEMI treated medically and randomized to clopidogrel versus placebo. So what ultimately proved is that the significant p-value DAPT provides greater benefit in medically managed STEMI patients. Now coming to the Clarity trial, where you got the clopidogrel as an adjunctive reperfusion therapy in thrombolysis in myocardial infarction trial, we got nearly 3,500 patients of less than 75 years of age, presenting with 12 hours of STEMI, treated with fatinolytic, with aspirin, heparin, and randomized to clopidogrel versus placebo. Of course, what is proven is that DAPT therapy provides significant benefits in STEMI patients treated with fatinolytic therapy with a significant p-value of 0.03, and you can see that the red line is far below the green line, which is actually aspirin plus placebo, and the red line denoting aspirin plus clopidogrel with a whopping 20% relative risk reduction. Again, coming to the clopidogrel evidence, clopidogrel for a high antithrombotic risk and ischemia stabilization management and avoidance. It's a Charisma trial that studied around 15,000 patients with multiple cardiovascular risk factors or non-CVD randomized to aspirin and clopidogrel for a mean of 30%. It's in fact a negative trial with routine DAPT therapy not offering any long-term benefits for those patients with high risk of atherothrombosis. So again, you got the current OASIS 7 trial where you got around 25,000 patients with the ACS, as I already mentioned, randomized to double dose of clopidogrel versus standard dose of clopidogrel and high dose of aspirin versus low dose of aspirin. What it is again proven is that you just need to remember that high dose of clopidogrel does not provide significant benefit in ACS. So low dose is enough for clopidogrel. Now, coming to all those guidelines, you've got the NSTEMI. First of all, if you take invasive management and conservative management, you can see that ticagrelor and clopidogrel takes a back seat, and prasugrel, of course, is not much of use. But ticagrelor is, of course, the 2A, and clopidogrel being a 2A, and prasugrel is a 3 indication. And suppose you go for coronary angiography, of course, the things all change. So that's CABG, of course. You need to continue aspirin as a class 1 indication according to the ESC, and Brazilian P2 Y12 early according to ACC, and according to ESC, so class 1 indication. And if you want to go PCI, of course, ticagrelor, prasugrel, and clopidogrel all are class 1 indication, both for ESC and ACC. And for medical therapy, prasugrel, of course, is class 3, but ticagrelor and clopidogrel test occur as a class 1 indication, and ESC also is stating ticagrelor as a class indication. Of course, prasugrel is avoided. Now, coming to STEMI patients that are going a primary PAC, there is no doubt you got the P2 Y12 pre-treatment, ticagrelor, prasugrel, all are class 1 indications. And if you undergo fibrinolysis, of course, you opt for medical therapy. But if you undergo coronary angiography and if you opt for CABG, it's again continuing aspirin and receiving P2 Y12, all are class 1 indications. And of course, your ticagrelor, prasugrel, and clopidogrel all are class 1 indications. While for medical therapy, in fact, ticagrelor and clopidogrel, of course, is class 1 for ACC, as well as for ESC, especially after thrombolysis, but prasugrel plays class 3. Now, coming to the stable CAD, we got P2Y12 inhibitor. If I got a high chance of PCA, it's a class 2B indicator. And if you want to go that is stable CAD with coronary angiography and PCI, of course, P2Y12 is a class 1 indication, clopidogrel, of course, class 1, and ticagrelor, prasugrel, class 2B. Now, coming to the recommended duration of DAPT in months with associated class and level of evidence, you can see that after stable coronary artery disease with no high bleeding risk, it's 1 month for BMS, and for DES, it is around 6 months. And the BMS, DS, etc. is always 6 months if for the ESC guidelines. And for high bleeding risk, BMS, it is 1 month, and for DS, it is approximately 3 months. Now, coming to the acute coronary syndrome, you can see that the American European guidelines states 12 months, and it's 6 months if you've got a high bleeding risk for DAPT. So coming to CABG, it's around 12 months according to the American guidelines with stable coronary disease. And again, it is no high bleeding risk, 12 months post CABG for stable coronary disease, as well as acute coronary syndromes. And there's a high bleeding risk, you can cut it short, around 6 months. And for medical therapy for stable coronary disease, it's approximately like it's a class 3 indication for a DAPT, need to continually aspirin. And for ACS, medical therapy, of course, it's around 12 months for both American and European guidelines. And for the American guidelines, if the bleeding risk is high, after medical therapy, you can continue the DAPT for 6 months, only for 1 month in the case of European guidelines. So that's the duration of DAPT. Coming to a little bit about the combination therapies that you can consider using. Of course, in the old age, you get so much of confusion whether to take this drug or that drug, or this drug in the morning and that one in the evening, whatever. So it's like the adherence to the medication drastically will come down. According to one study by Badoletti and Delofano in Circulation and all, you can see that the complaints to the drugs are not up to the mark. In fact, aspirin has got a self-reported adherence of around 83% and consistent adherence of around 71% only, while lipid-lowering agents is again coming down to 63 and 46, beta blockers 61 and 44, aspirin plus beta blockers 54 and 36. And if you take aspirin and beta blockers and lipid-lowering agent, the complaints is far less. In fact, if you take drugs separately, it's around 39% and 21% respectively. So more than it's actually more than 2 consecutive follow-up surveys over around 6 plus or minus 12 months. So polypill or combination therapy, in fact, can improve the compliance. There are potential strategies to improve the or optimize the secondary prevention therapy after ACS. You can take participation in a comprehensive multidisciplinary cardiac rehabilitation program after hospital discharge. You need to coordinate with a primary care provider and other specialists, of course, if the therapeutic plans to be made and objectives as to be formulated. Of course, you've got to recheck and reinforce advice on all lifestyle changes, whether it is diet, whether it is physical activity, whether it is smoking cessation, especially during follow-up visits. Now, check and optimize doses of all the indicated secondary prevention drugs, use of specialist support, nicotine replacement therapies, varenicline and or bupropion individually or in combination for patients who is not quit or restart smoking has to be taken care of. Now, use of acid-media and PCSK9 inhibitors in patients who remain at a high risk with LDL cholesterol more than 70 despite a proper diet and maximally tolerated dose of statins, and even acid-media has to be taken care of for PCSK9 especially. The use of a polypill or combination therapy in patients with suboptimal adherence to drug therapy has to be considered. SPCs, polypills are being shown to improve the adherence. Use of SPCs is associated with a 29% increase in adherence and persistence versus the same drugs given a free drug combination. In fact, I can see that it's a whopping 29% according to the ESC Munich studies. Reports. SPC, what does it do? It is convenient, it's compliant, it has got a better effect, it's got less side effects and low cost, in fact. Now, if you take all these drugs separately, you've got monotherapy. Of course, if the cost is too much, the need for more antihypertensives and more side effects, and it's quite inconvenient, and the patients often will be incompliant. Now, coming to the cardiovascular prevention, it is in fact the equation is quite difficult to solve. So the triple drug combination has to move forward. Now coming to the aspirin, a little bit about aspirin. In fact, aspirin clearly has got a net benefit over cardiovascular events avoided than significant bleeds caused. In fact, in setting of established cardiovascular disease or secondary prevention, according to the European Heart Journal. So, in fact, it has got uses in stable angina, and STEMI, and it's an oral, it causes organ activation of cyclooxygenase, and it's reversible, and it has got a loading dose of around 300 milligram and a maintenance of around 75 to up to 300 milligram. And of course, what is important is that it's quite, the advantages is that fast onset is very cheap and cut experience, and sort of variable response to negative side. So aspirin is the standard for monotherapy in patient antiplatelet inhibition, and the advent of a more potent P2Y12 inhibitor may redefine the role of aspirin as monotherapy in secondary prevention and DAPT therapy following PCI. A little bit about clopidogrel. In fact, it's an oral kinopyridine group drug inhibition of ADP receptor P2Y12. It's a prodrug. The loading dose is around 300 to 600 milligram, and a maintenance dose of around 75 to 150 milligrams OD. And the advantages are, of course, it is used in stable angina and STEMI, and it's quite effective, and it's quite experienced, and it's quite a cheap drug. So another thing is that the disadvantage is that it's slow onset of action and variable response. And a lot of trials supporting clopidogrel, as I've already mentioned, the cure trial, PCA cure, clarity chemistry, and so on. And clopidogrel is likely to be, in fact, I repeat, likely to be replaced with more potent and reliable P2Y12 inhibitors. The clopidogrel is still a formidable opponent. In fact, it's a clean drug with few side effects. It's quite effective. It's usually used once daily. It's quite cheap. In fact, and it's got familiar to most of the practitioners. In fact, it's the second highest selling drug ever. You've got the GPs, you've got the internists, you've got the cardiologists, neurologists, and vascular medicine people, and even surgeons prescribing the drug. And it's got multiple broad indications, and has got global use. Extensive clinical trial program in STEMI and stable angina and STEMI, stable CAD, elective PCA fibrillation, PAD, TIA, and stroke, and heart failure. Coming to clopidogrel spectrum, across the spectrum of CAD, in fact, it's used in STEMI, acute STEMI for the clarity trial, CABG trial, and so on. The clarity has shown that around less than more than 20% cardiovascular reduction, mitral infarction, and re-ischemia, and CABG trial shown more than 9% the death reduction in MI or stroke. And it has been proven in STEMI to have at least a 30 days benefit. Now, coming to unstable angina of STEMI, in STEMI, over the cure trial, more than 18.4% CV death and MI stroke reduction, and at least 1 year benefit. The CREDO trial, again, more than 26.9% reduction in death and MI stroke, and of course, PCI, it's got 1 year benefit or more. Long-term secondary prevention, over the CABG trial, it has got more than 8.7% risk reduction for death or MI or stroke, and at least 1 to 3 years benefit. The Charisma trial, more than 7% mortality benefit, high risk vascular disease, up to 3.5% benefit in symptomatic patients only. A comparison of the efficacy between different statins, you got rosuvastatin, atorvastatin, sima, and pravastatin. You can see that rosuvastatin is the most potent. Approximately 50% baseline cholesterol is reduced by 20 milligram of rosuvastatin. So it's almost like taking to the equivalent of more than 40 milligrams, even up to equivalent to approximately 80 milligrams of atorvastatin. So summarizing, 3 drugs single pill combination can lead to a decreased event rate by enhancing the compliance, by improving adherence, and being cost effective. That's all for the time being. Thanks for the patient listening. Thank you.
Hello, sir.
Hello.
So, sir, right now there are no questions in chat box.
Okay.